This is Professor Ariel Ortiz Lagardere streaming live from the International Bariatric Club studios in San Diego, California. It is a great honor to announce that today is the 104th IBC University of Oxford Surgery Webinar. The IBC University of Oxford Webinar series was created during the beginning of COVID-19 pandemic in March 2020 and is a collaboration between the IBC and the Nuffield Department of Surgical Sciences, University of Oxford. The aim of the webinars is to provide free and first-class surgical education globally to improve patient care. In addition, the 5th IBC University of Oxford World Congress is being held September 17th through the 19th of 2024 at the University of Oxford, United Kingdom. For more information, go to ibcclub.org. The theme of today's multi-streamed 104th IBC University of Oxford Hot Topics in Bariatric Surgery exclusive event is the next generation of surgical robots for weight loss surgery, artificial intelligence, automation, and global access, and will feature experts from the United States, Chile, India, Italy, Mexico, and France. The IBC University of Oxford Webinar Partnership would like to thank Zoom Video Communications, Laparoscopic Surge, Bariatric News, and Bariatric Channel for setting up and promoting this regular scheduled online academic series. We would also like to thank our platinum sponsors, Stryker, Medtronic, David Medical, our gold sponsors, Ethicon Endosurgery, USGI Medical, XNY Medical, ConMed, Reach Surgical, Carl Storz, Blue Sail Surgical, our silver sponsors, GT Metabolic Solutions, our bronze sponsors, Intuitive, Moon Surgical, Arthrex. The chairs of today's webinar are Professor Santiago Horgan from the United States and Dr. Jorge Bravo from Chile. Professor Santiago Horgan is Professor and Chief Minimally Invasive Surgery and Vice Chair Business Development, University of California, San Diego. Also Director of Metabolic and Bariatric Institute and the Director for the Center of Future of Surgery at the Department of Surgery, University of California, San Diego Health, United States. Dr. Jorge Bravo is Chief Robotic Surgery and Staff Surgeon, Gastrointestinal, Bariatric, and Metabolic Surgery, Clínica Santamaria, Santiago, Chile, and also Assistant Professor of Surgery at the University of Chile and President of COLSIR, the Latin American Collaboration of Robotic Surgery, and also Bariatric Channel Innovation Director. I will now ask Dr. Jorge Bravo to introduce our esteemed moderators, Dr. Arun Prasad from India, Professor Marco Raffaelli from Italy, and Professor Juan Roberto Gonzalez Santamaria from Mexico.
Thank you, Ariel. First of all, I want to thank Professor Harris and the IBC for this incredible invitation to an exciting topic for all of us. And what better than having a brilliant panel of professors to discuss this topic. I have no doubt that all of them will blow away our imagination with the great current technological advances and future trends. But at the same time, they will show us how to incorporate these tools into our daily practice and how to improve access to this technology. Now, I want to introduce you to this group of renowned professors who will be our moderators. I want to tell you that I am pleased that each of them represent different regions of the world with our realities, such as America, Europe, and Asia. I am referring to Professor Marco Raffaelli from Italy. He is the head of the division of the endocrine and metabolic surgery from the Policlinico Universitario Agostino, Rome, Italy. Full professor of surgery, Università Cattolica del Sacro Cor, Rome. Board member, Italian Society of Surgery of Obesity and Metabolic Disease, Director of Postgraduate School of Bariatric Surgery. The next, Dr. Arun Prasad from India. He is consultant surgical gastroenterology, bariatric and robotic surgeon, adjunct professor and clinical tutor in the Prasad Apollo Hospital, New Delhi, president of Obesity Surgery Society of India, and president of International MGB OHB Club of Bariatric Surgery. And finally, my friend, Dr. Juan Roberto Gonzalez Santamaria. He is consultant, minimally invasive bariatric and robotic surgeon, Centro Médico IBC, Mexico City. Now, I leave you with Dr. Horgan to begin the lectures.
Thank you, Jorge. That was the presentation of our great three moderators. It is a true honor to introduce a leader in robotic surgery. I know Andre for a long time. He's a good friend of mine. Really a true visionary. He's the vice chair of surgery at Orlando Health System in Florida, director of bariatric and endoscopic surgery, and the director of the Bariatric Surgery Fellowship in Orlando. And he's going to talk to us about the Da Vinci 5, the new robot, 22nd century innovation for the 21st century surgeon. And I think that Andres and me are the only ones that use every robot that Da Vinci has built, right, Andre? And we go way back. So the floor is yours, and I'm sure that you're going to kill it. Thank you.
Good morning, everyone. Thank you, Dr. Horgan, for the kind introduction. We go way back. Like I said, you interviewed me for fellowship, and look at us now. We're here, but you are a giant on robotics for sure. Yeah, so I have the honor to talk about this platform, the new platform, which was part of the trial, actually. We talk a little bit of that about that too. So this is just a little bit of introduction of my team. Most of you have seen most of these esteemed colleagues. I do have to say that the Da Vinci 5 is only indicated for sales and use in the United States. It's not available yet outside North America, or USA, should I say. So, people ask about the making of, I kind of really like this slide. Talk about expert. We always got invited because we're expert, and you are not born an expert of anything. Basically, you is with talent or years of work and practice and coaching that you are able to develop your skills and your talent. That you're not born with that, right? When people say that we do a lot of robotic cases and so forth, and we are where we are just because of the amount of volume that we've done it, and we've been exposed. Same thing with Dr. Horgan. And some of the physicians they've been pioneers in robotics for many years. That's who you develop. But none of us are born with it. So I think I really like to see what's happening. We really are exploring new platforms. I love to see the advancements of the platforms outside the United States, as he's going to be showing here. Unfortunately, right now, there's only one platform. There's FDA trial, that FDA approved here, which it's an amazing platform still, which we'll talk about the new one. This little video that passed here is actually my son. First time you've ever sat on a console. I did something and he saw it and then he tried to mimic. So it's pretty impressive that robotic platforms enable surgeons to be better versions of themselves, right? So I'm a true believer of that, right? It's a platforms that levels the playing field. So what are the differences, right? What would make a platform better than other? What are our visions, right? For me, it's always about what's next, right? So single port versus multi-port. Why we still have to do 5, 6 incisions, 4 incisions? Why can we not do everything with one? And I think we're moving on that direction. There is a new single port that is being done in Asia right now. It's pretty impressive, actually. So in the future, maybe we can talk about that. Endoluminal growth, right? Yeah, one company is EndoQuest, people are still talking about it and doing it, but I think there's more to come on that. And I think when that platform starts, I think it's really going to change everything else that we know about surgery. AI, right, with simultaneous assistance, right? Surgical teaching, incorporating patient data into the case, data analysis. It's all about data analysis nowadays, right? When you look at the evolution of Intuitive, you see they started a true robotic company. Now they're still a robotic company, but now they're really a data analysis stapling company and so forth, right? A teaching company. So they have become more. This new platform is allowing them, which I'll show you in the end, what their vision is going to be. That's what it looks to me. So the key technology for me, right? driving manipulation, master device with teleoperation, right? Imaging technology, vision assistant with AR, VR. I think the 3D perspective, able for you to do picture-in-picture with interposing imaging, which it can be done already for urology. Now we're starting a trial for thoracic. Haptic feedback would be great. Would it help me? No, it actually would not help me at all, or Dr. Horgan, or anyone that's been around robotics for many, many years. But I think as a teaching device, so people they starting now, would definitely help tremendously, right? Because it gives them that feedback and the less chance of having injury on their manipulation of the bowel, the spasms, and so forth. Autonomous surgery, they'll be great, but I don't think we're there yet, right? So when you look at XI to DV5, is this a step in the future? By all means, right? A lot of people, when they saw the DV5, they have a different impression that they were actually thinking about it doing. It would be a much difference in terms of the hardware perspective. There is a difference in the hardware. Remember, the last time was 10 to 11, 12 years ago, the XI came out, right? So the hardware perspective, the chip power is different, right? There is a difference on the console. There is a difference on the cart, which we'll talk about. So I think that is the right step in the future, right? There's always room for improvement, but it's definitely the right step. And we were able to accomplish a couple of things, right? The teleoperation, imaging technology is very different. The camera power of sensitivity of markers is tremendously high, and you're actually exploring new wavelengths that we can use for markers. Haptic feedback, by all means, that has been improved. They've instrumented for that. Wire-driven manipulation, for sure. So this is where we are. We have the early DV5 experience. We were able to do, we were the PI for the trial. We had 53 patients last year. There were 4 sites. Orlando Health has the highest volume of enrollment. We had to do cases with the DV5 in the same time. As soon as we got down, we jumped on the XI and did a couple of cases back and forth, right? So instead of 53, it was 106 cases that had to be done. Just for comparison, right? There were 0 conversions, 0 complications. There was no adverse effect that was reported. The only cases that are still being followed are the cancer cases from the thoracic perspective. And so far, no issues that we haven't seen. The other, as you can see, the robotic, the newest, the most advanced integrated system for sure. When you look at it and you understand what's happening with your operating room, what they're trying to do is actually consolidate everything into the system, right? So it is designed for your feedback, which you can have different levels, low, medium, high, which you give about 43% less force of tissue. Why is that important? Very important, especially if you're a teaching institution, right? The less of your residents or fellows or initial surgeons learning how to use, you can regulate the feedback so they have less chance of having tissue damage, right? The vision, the most realistic 3D image I've ever seen on a camera so far. And I've been trying some other ones. The image and the light perspective is changing the game for sure. And the picture-in-picture also. And for me, I've always been a big ergonomic person in terms of what I look for robots. They're always the downside of robots, always been the chair and the console. The chair has not been fixed yet. So hopefully the next generation, they'll fix the chair. But the console, for sure, they fixed it, which I will show you in a few minutes what I mean by that. The workflow on the operating room, tremendous change. You have full control on your console. You have control from complete integration of insufflation, of the boom, lights, and so forth, right? The only thing they have not given to the surgeon yet, it is full control of the stapler. But my understanding, the processing give this back to us. So we will decide when to stop and when to fire and when not, right? You having full control of it, especially smoke evacuation, instrumentation, so forth, you are able to decrease your operative time. How much of the operative time is going to be, I'm not sure yet. I think it only be done with multiple cases being done by high volume centers. We'll be able to see how much will be the decrease in time. And with time, we also be able to quantify that per year, how much is the cost savings. The platform itself, AI, we all know, in terms of your My Intuitive app, which you can analyze your data, but there's a difference now. My Intuitive app is completely in sync with the robot now. As the case is done, you have access to your video recording, markings, data analysis. You have over 110,000 times the computing power compared to the XI. So we might not see it, but there is a difference. That's why we're able to have all of this advanced processing and AI-based calculation capability as soon as your case is done. So it's called Case Insights. The Case Insights is going to give you haptic feedback, how much power you use, decrease, time, analyze your movements. So I think that alone will give you the data analysis that we need to make ourselves better surgeons, improve ourselves, right? As we're talking about the Case Insights itself, we help you for training purpose, which will increase your skills, improve patient's outcome. No questions about it, right? As you're able to analyze, as I do it now, record my cases, especially my revision cases, because if something goes wrong, I look it back, see what I did wrong and so forth, which you should all do that, right? This is what I'm talking about. This is my picture. I have a C5, C6 disc that I had to replace. So for me, positioning has been a big thing. And that really made me jump into robotics back in 2014 because of my neck issues. When you look at the picture on the left, this is how I adjust the new console, how I adjust my XI now. That is, if you measure the degree of bend of my neck is about 30 degrees bend. If I adjusted the way I had to do with human factors engineers to help me align the way you need to be aligned, there's a zero gravity or zero position or angulation of the neck. That alone, you're looking straight, very comfortable position. So you can put that console how you want it. For me, when I get my DV5, this is how I'm going to do it. Neutral position. I won't have any more back pain, lower back pain. Sometimes on a long day, you can have some spasms. Mentoring. There is a thing, the robot's connected with the hub, which hub is also included in your tower now. So you can do the telemonitoring, you can do live cases. So again, if you look at it, what's happening, right? The challenge that Intuitive is trying to solve is not just the system, right? You look at all of the things that we have on a robot or on the OR, like insufflators, electrocautery, energy devices, and so forth. Why not try to get all of those maximized into one tower and the robot itself and decrease the amount of space that you need, and also centralize all of it in one company, which also brings some questions, which we can discuss this later. As you see, if you look at this picture, right, this is exactly what they're doing, right? They're able to put most of the things that we need on our OR into one tower, one robot, and one console, fully integrated. Now you have insufflation, smoke evacuation, continuous insufflation, energy device, whatever energy, bipolar, monopolar, vessel sealer, harmonic, whatever, you can be all connected to it. In plus the data analysis power, all into one, and also recording, able to analyze the recording too, all into one company. Thank you very much for the opportunity. I hope this gives a little bit of what's down, and there's more coming on down the pipeline.
Andres, that was, as expected, an excellent presentation. You talked briefly about the haptics feedback, and I think that that's probably the biggest future in the new robot. I do agree with you with the console, because I have numbness in my fingers in 2000 after I started doing robotic surgery, and I think that the ergonomics is going to be a game changer. But can you talk to us about the haptic feedback, and it really works, or is it more digital feedback? Because I know you can change the strength, right? So
yeah. Great question, Dr. Horgan. So So for me, right, the haptic feedback will actually mess us up, right? Because we have our vision, we develop our vision and your peripheral vision, and we have an idea how things are working for ourselves. For the haptic feedback that's developed by the robot, I think it will work for teaching residents so they can cause less trauma. You feel resistance more than like it's just a resistance, like attraction and contraction, basically, right? So you can go medium, low, medium, high, right? I think in terms for teaching, for people that are starting their journey, I think it's going to be good to decrease tissue damage for that perspective, especially when you're doing bowel counting. But for like seasoned surgeons, robotic surgeons, I'm not sure I think it's going to mess them up.
That's exactly what I thought when I felt, the fact that you can change the strength is not real haptic feedback, it's more digital oriented.
Yeah.
Okay, the panel has questions.
Yes, Professor Andre Teixeira. Beyond question and excellent talk. As you recall, when Intuitive Surgical made the transition from the third for fourth generation, one of the challenges that they had to face was the lack of compatibility between platforms. Today, we are being part of the transition from the fourth to fifth generation of Da Vinci surgical robots, and we see progress in force feedback, the improvement in ergonomics, and better operational efficiency, as well improvement in workflows, of course, the ability to develop the AI with the computing power offered by the Da Vinci 5. Do you, as the Da Vinci surgeon, think that Intuitive Surgical forgot to mention something? And indeed, do you feel that the current needs are solved with the different generations?
So if I understand the question correctly, you're asking me if the new platform achieve what they wanted to achieve for the new generations? Is that what you? I'm trying to understand the question a little bit.
Yes. Do you think that in this time, Intuitive Surgical forgot to mention or include something from this new generation, and you could indeed, do you feel that the current needs are solved with this new generation?
No, I think the needs that some people had, some surgeons had in terms of feedback and data generation and power analysis, right? I think they were able to deliver it, right? Is there room for improvement? There's always room for growth and improvement, right? But I think I know there's other things that are coming down the pipeline that's going to complement the DV5 that it's going to be game changers too, right? And the time when it comes, they will deliver that. Is it a XI to a DV5? It's going to make a big difference if you go from XI to a DV5 in terms of the procedure itself. Right now, I don't think so. But does the DV5 offers some other things that you might want to have it? Probably, like data analysis, imaging capturing, some feedback perspective. But the instrumentations that you have on XI, you can use on DV5. Unless if you want the haptic feedback instruments, you have to buy those ones. But the instrumentations are the same. Make sense? So the jump was not like SI to XI. That was a big jump, right? So that's what I think.
Hi,
Thank
this
you.
is Prasad from India. I could understand the previous question as well. And I also feel that, after 12 years of usage of Intuitive, maybe the haptic feedback might create more confusion than solve my problem, because we have got used to the visual feedback and the haptic feedback might create more confusion. But however, my question is that when you talked about the forced instruments, is that something which is available on all the instruments, or it's just the bipolar?
No, right now there's a couple instruments that are available, right? Needle driver, bipolar. But you don't have to use it, right? You can turn them off, right? Like, for example, for me, and I'm not gonna buy them because I'm not gonna use it, right? But if of course my house is gonna have it, but if I'm teaching, right, for the residents and fellow, that's what comes in, the teaching perspective and starting. For me and you, Jorge, Santiago, it's doesn't make sense for us to use it, right?
Sure.
But for the new generation.
Yeah. One more question was that when you talked about more control, do we have control on the robotic arms, like, patient clearance, movements of the robotic arms, which are normally done by the assistant who's standing at the patient side? Do we have some control from the console itself?
No. So in terms of moving of the arms and putting where you need to put, it has to be done at docking. Or if you have some collision, they still have to. So you don't have that control in moving the arms wider, closer, outside. You don't have that.
Okay, thanks.
Yeah, you're welcome.
Any other questions, or we move on? Marco from Italy.
Yes. Excellent presentation. Thank you for giving your feedback with the new generation of robot. Starting from the discussion and from the presentation you did, what do you think it could be the spread of this new platform, and what is the role, at least at the present time, taking into account that is a limited diffusion, a limited.
I like that question, Professor. So, as with any new product, right, there is a limit release and so forth. So I think there's only like 457 robots being released this year. The asking capital is pretty high for it, as Santiago probably exactly. As you know, so yeah. So for me, it's a pretty high ask for anyone, right, to buy it. So I'm not sure what they're gonna. I think they're gonna have a better impulse or sales when they start to take the excise down payments, right? Because it's a very hefty price right now. For that reason, we don't have it, right? We have 28 excise, but we don't have. It doesn't make sense for us to spend $3 million for each, right? To substitute them doesn't make sense.
Thank you for your quite clear and honest answer. Thank you so much.
Always honest.
Thank you very much. So it is my pleasure to introduce Dr. Amit Bandari from India. He's director of the IRCAD India and director of the Bariatric Robotic Indoor in India, and he's also associate professor in the Department of the Surgical Gastroenterology at the Sri Aurobindo Medical College and Postgraduate Institute in Indore, India. So he has recorded his presentation because it's still flying, but will be with us at the end of the webinar.
Good evening, everybody. At the outset, I would like to thank Dr. Harris Khwaja for inviting me to the 104th IBC University of Oxford seminar. Harris has asked me to talk about the next generation of Asian robotic platforms, balancing the futuristic functionality and financial affordability. I bring greetings from IRCAD India and from Sri Aurobindo University and my Bariatric Center here in India. This building which you see here is under complete renovation. And the next time you're going to come here, this will be the IRCAD India building, which would be one of the largest training center here in the Asia Pacific region. This is our bariatric training center, 100-bedded, only bariatric specialty hospital, one of the largest weight loss surgery hospital in Asia. And this is the medical school, and it's a big, huge 118 acres of sprawling campus. So I welcome all of you to India to visit us. These are my disclosures. We have done close to 22,000 bariatric procedures, and as you can see, we have done good number of robotic procedures, around 2,000 of them. Manuel Galvao Neto is a director of bariatric endoscopy services at our center, and he's also heads IRCAD India as one of the scientific as the scientific director of IRCAD India, and as one of the innovators here in our university, guiding us through. This is Professor Merescow and all of us, the team of IRCAD India. So you can see that my robotic growth did not began immediately. We started with this bariatric program at a new hospital in 2010, and then we started robotic in 2013. And this is my experience of around 2,000 cases, more than 2,000 actually, with robotic sleeves, gastric bypasses, mini gastric bypasses. India is one of the places, and specifically Asian countries, where cost dynamics play a very important role. And that's why all these advantages with robotic system will only convert into a distinct advantage for the patients if the patients get the cost benefit out of what we are doing. If there are no cost benefits, even if we do a surgery which has lesser complications, will not have a lot of appeal. So making robotic surgery available to patients, or the correct term would be democratizing robotic surgery, is the ultimate aim in the Asian region. So my part of the presentation would stress upon more of robotic systems, which really have changed the way in terms of the economics, because we have at least 120 robotic companies at present now, which are into different stages of innovation. But the point is, which are already approved and making things economically viable. Here is Dr. S. Srivastav. He is an Indian origin cardiac surgeon who developed a company known as SSI Mantra. He's a very gifted cardiac surgeon who did his entire residency here in India and then went to US. He was the first one to buy his own hospital in Texas, raising $50 million way back in 2000. And then he came back to India to develop the Indian robotic system. And with a lot of difficulties, hardships, trials, and obviously taking a very difficult path, he developed what we are proud of, the SSI Mantra, which is the first Indian robotic system, which is manufactured and marketed from India. And it's one of the most affordable robotic system, which will make its mark across the world. I think more about SSI Mantra, it's more data-driven, designed for a long-term customer relationship where patients get the benefit at the end of the day. India being a very fast-growing economy, the health market with significant unmet needs for medical technology, SSI brings a very cost-effective model. It's being approved by the body called as CDSCO in India. It's one ISO certified. It's eligible for sale in 50 non-FDA and non-CE approved countries, which does not require any further approval. And the FDA and CE approval process are in the process. In India, we have done 900 plus surgeries with this system. 31 systems are installed, which is, I have seen the growth of robotic system in India. But SSI is one Asian robotic system where one of the fastest installation. The surgeries are done in cardiovascular, thoracic, head and neck, gynecology, urologic, oncologic, general surgery, and obviously bariatric surgery, which is our specialty. The focus is, more on reusable instruments where they can be used without putting a lot of cost to the patients. The concept is on freedom of patient docking, modular robotic carts, beautiful patient cart connectivity, absolute stability in terms of the parking locks, smaller individual cart footprint, advanced touchscreen control, and multi-speciality use. I think these are the things which everybody is looking for, because 3D visualization is available, but something called as preoperative guidance and a chip-enabled instruments are what we are looking for. Because this will not only improve the patient experience, but also the surgeon's experience. And also open-faced console with improved ergonomics. That's what we are seeing. Now, here in SSI Mantra, we have a innovative open face console. We have a very reduced variability and very lower cost per procedure because you can reuse the instruments. And that's because more often it is commercially validated that the recurring revenue from the sales of instruments, accessories, and services, they've been completely taken away by this particular team. The founder was himself a cardiac surgeon. So he had 30 plus years of experience, Dr. Srivastava, and he has done 1400 robotic surgeries. And then he took a team of surgeons, engineers, and industry veterans to develop the SSI mantra. Now, if you will, I don't know how many of you have used, but it's a very intuitive platform where you have a login, you have a patient data input, you have ports, arm docking, and several others which are done in a very simplified way. So if you see, this is how the dynamics of SSI mantra works. Similarly, like other robotic system, it has a patient's card, it has a surgeon's card, but the instruments have chips. And so the chip does not defy even if you reuse it, and the instruments are very, very robust. You have a 24-inch touch monitor for system controls. There is a head tracking and safety features, and also a 32-inch 3D 4K monitor for true depth perception. As you can see, the surgeon can sit wearing his specs, and he can see the entire system. And now we are seeing more and more that even the patient's cart where the assistant is sitting will also have a 3D monitor. So that's even beautiful, even for the assistant who is doing it. And so everybody has 3D vision. You know, most other robotic systems where we do not find a 3D vision for the assistant side, here we have. We have a preoperative software for the guidance of the anatomy. The 3D endoscope is articulating, which is another beautiful thing. There's multimedia recording facility, university safety features, and obviously, needless to mention, a UPS backup. So what I feel is that, you know, they are into different stages of developing the instrumentation. They have virtually everything, and the only one thing I think they are trying to develop now is a harmonic, which they told me that they're going to develop in a month's time. They have the anastomotic connector activated by vascular surgeon, or a tableside assistant can felicitate for the coronary anastomosis, which is, I think, very rare. Obviously, Dr. Srivastava, coming from a background of vascular and coronary surgery, will make vascular surgeries much more easier by this particular system. Also, we have multi-fire clip applicator, which is something unique to this particular system. So what I feel is that this system is something which is innovating very fast. Now they are coming up with SSI 4. So they have a virtual surgical training module. They have holographic anatomy module in which a VR can be worn by trainees, and they can see, they do telementoring, and they have artificial intelligence powered DICOM data processing. So I think these are things in a SSI mixed reality headset, which is head tracking, stereoscopic endoscopic vision, 106-degree freedom of movement, and you know, this is the future where the screens will completely go away, but it would be a big SSI reality headset which will be worn by the surgeon, and they will be doing all these surgeries. So what I feel that SSI Mudra, SSI Mantra, and SSI Maya, the future softwares which they are going to develop for the future of surgery here in India, Asia, and across the world, going to be very innovative. I would say it's a comprehensive ecosystem and very collaborative too. These are the surgeries which they have done. In general surgery, you can see cholecystectomy, fundoplications, bypasses, gastrectomies, hemicolectomies, sigmoids, adrenals, appendix, and bowel, virtually almost everything. Cardiac has a long list because this is more of a developed by a cardiac surgeon, so he has his own individual preferences, but he has been, you know, developing them for urology, gynec, and head and neck cancers. Now, SSI Mantra is 3 to 5 crores, which means it's very cheap. It's the cost would be around, if you take it, around $2 to $3 million, and I think that's the proposition we are having. Affordable option because you can reuse the instruments. So I think they are coming up on a model where you can take a robot on lease or on rent, and so there is no initial cost for a long period of time to the surgeon. So I think this is the cheapest robot I have heard of in any part of the world. And I seriously believe that at least I'm seeing in India, at least 100 more installations coming up. I talk about another Chinese robotic system known as Microport. Because of IRCAD India, we are in touch with the company, and Zhou Chang is the innovator who started as chairman of the board, including Hiroshi and Wei Queen, who are leading this particular Microport system of robotics. They have DF Vision 3D electronic laparoscope for 3D imaging for general surgery, robotic bariatric surgery, and this is the endoscopic surgical system known as Tuomi, and they are using this as the same like a surgeon console, the patient cart, and the image vehicle. They have teleoperation technology, and they are the ones who are trying to do this surgery with Professor Vipul Patel in US for doing the surgery remotely. So I think this is also one of the robotic systems, the Chinese one coming up, also seeing installation here in IRCAD India, and several other Indian hospitals have application in urology, general surgery, gynec, and thoracic surgery. They have a robotic system for specifically known as Mona Lisa, ISARBot for prostatic biopsies. I think that's going to be a game changer because we are seeing the prostatic biopsies being taken in a very good way, high yield, and no missing the area of the interest. Also, they have a Skywalker orthopedic surgical robot for joint replacements, which creates 3D hip and knee joint models using preoperative CT scan data, and they're doing a great job. We are hoping to have these installations here in India. I would say that the future here is that we're going to go without a screen. So you see here, we're going to have a screen which will be virtual. We all going to use the robotic systems, but it would be through a headset which we wear virtually, and the screen can move to all parts of the operating room just by the touch of the finger. This is an endoscopic procedure done by me and Manuel. We are not using robotic, but what we are trying to point out here is that this is the future of surgery and endoscopy, where you're going to have a virtual screen in front of you, which you can take to any part of the operating room, just like Manuel is doing. He's positioning it to any part of the operating room. And similar is going to happen with the robotic systems in future. We similarly did in the same way, like we did the robotic, we also did one of the first bariatric procedures with the robotic system. And as you can see, I'm taking the screen to any part of the operating room using the fingers. This is available in 2D, 3D with a very simple interface, and I can just change the position. So, I'm seeing that three developments which I feel is going to happen. The one, the screens are going to be obsolete even in the robotic system, just like what I am doing. Not going to have screens in the robotic system. The big screens, they all will be in the form of a headset which can track the movement of the fingers. That's the first development which is going to happen, and it's going to happen very soon. The next generation of robotic systems will have just the surgeon wearing a headset and virtual screens. The second development would be we're going to go away with those heavy bulky arms, but single instruments will come and they will be connected either by Bluetooth to the console or some other technology or laser, where we're going to have such huge system which occupies such a large space inside the operating room. That's not going to happen. And the third and the most important is the usability of these instruments. So robotic surgery will be coupled with artificial intelligence for illustration of the anatomy. You put in a scope inside any abdomen and you're going to know where the common bile duct is, where the pancreatic duct is, or where the left colic artery is, or where the hepatico-pancreatoduodenal artery is. You're going to know everything just by putting inside the scope. And along with this illustration, you're going to see reusability of these instruments. So I'm seeing a lot of future in robotic surgery, not only in India and Asia, but across the world. Yes, the cost will be a very important deciding factor for all of us to determine. And at the same time, it would be that how we transfer and democratize the benefit of robotic surgery to patients, even if they cannot afford the surgery. So thank you very much, Harris and IBC, and we are ready for any questions.
Okay. Thank you so much. So, Professor Prasad, will you introduce the next speaker? We are going to move on to the next speaker.
Hi, sorry, I think it's better you introduce because I was not prepared for the introduction. That was not part of my brief, so I don't have it in front of me right now.
Okay, so no worries. I can introduce. So we're going to introduce Dr. Benjamin Cadier, who is a consultant in minimal invasive surgery and bariatrics and robotic surgery at the Digestive Disease Surgery Institute in Saint-Laurent, Dubai in France. Benjamin is going to talk about the Maestro robotic platform, minimalism, portability, and scalability redefined. And I have the opportunity to test this platform many opportunities. I think that it's a nice switch on bringing robotics to the assistant surgeon. And I would like to see what Dr. Cadier and Benjamin has to say about this. So we look forward to your talk.
Hello, thank you for the introduction. Sorry, I'm sick for a bit of this, so excuse my voice. But thanks to everyone. Thanks to everyone involved in this webinar. Obviously, it's an honor and it's a pleasure to be with you right now. So I'll talk about the robot that a French-American company developed, Moon Surgical. Not everybody had the chance to put his hand on it right now. But it's a robot that had been developed by Moon Surgical. It's called the Maestro system. And it's a robot that was developed to enhance the comfort and the control, the precision of the surgery, obviously for laparoscopic surgery. Probably the idea is more having the machine adapting to the surgeon than what we can see with with bigger systems where the surgeon has actually to adapt its practice to the machine. So how does it work? Well, I'll just take the points over there. How does it work? The hardware is a cart like this, not so big. You can see it on the left of the screen with Dr. Macaulay, and it consists of two gravity-defying arms over there. Their first part is this horizontal part, which can go up, down, back and forth, coming in and coming out, which gives you a lot of possibility in terms of adapting to the OR, adapting to the table and all the other energy instruments that you can find. Those two arms that will be in the operative field are extremely versatile in terms of their movement, and I will show you with a small movie how light it is and how easy it is to use. We'll talk about the learning curve after that, but it will take 10 seconds because there is actually no learning curve for this robot, and those two arms are extremely light to move on, and they will adapt so well that you will always have space for your hands, space for your elbows and your shoulders, so you will never feel any kind of conflict. The whole machine is powered by a computing system built with AI inside, so it's also connected through 5G to collecting the data and also transmitting data. So you have this interface, this screen, which is obviously interactive and where you can set up all the parameters of your surgery to come and which surgeon is going to perform the surgery. The AI adapts itself, so that's for every surgery and every surgeon that is going to perform with the machine. For every surgery, the machine is going to adapt better and better, so it fits perfectly the way you operate. If you operate a little bit faster, if you operate with a screen that is a little bit more stable or anything. So a little bit about the pilot study. We conducted the study in Europe, in France, in the north of France. It was directed by my colleague and friend, Dr. Mercoli, and in the south of France, with my colleagues down there. We implicated a gynecologic surgeon, and I will try to show you a little bit what we did during those 200 cases. It went from just general surgery to bariatrics, but maybe a little more talkative would be that these are all the type of surgery that we performed during the pilot studies. And I have to say, actually, my third case with the Maestro system was a minimally invasive Ivor Lewis esophagectomy. And I had absolutely no time of adaptation to the machine. The machine adapted to my practice perfectly. I even did the thoracic part completely in solo surgery. We did some hepatectomies. We even did some APR, some gynecology, as I told you. Sorry. Yes. So a little bit about the machine in itself and how you have to use it to start the procedure. It has two consumables, custom system drape for the two arms, and those small couplers that will adapt to any kind of instruments from 5 to 10 millimeters. These are actually all the instruments that we used. We use very different instruments from Dr. Mercoli to my practice in the south of France, and it adapted perfectly to any instruments, as I told you, in between 5 to 10 millimeters. From Stores to microfrance, depending on the instrument you're using. About those 200 cases, about 10% of them were performed completely in solo surgery. So that means you are only with the machine. And as I told you, it's like a super assistant that will never shake, never move. You will never have the second arm is usually used as a retractor. So this retractor will also be extremely stable and will allow you to focus perfectly on your right and your left hand. This slide is to show you how versatile the machine is. So here is Dr. Depp, my colleague, operating from the side with those instruments that are coming from above. You would say the angle of the arm is coming like an eagle eye. And here I'm in the French position, and you can see that to have maximum space for my left hand, as I will have to move the bowel a lot. It was actually a gastric bypass for this matter, I think. But this will allow me to have a lot of space, and the arm is coming from below. So this is to show you how versatile the machine is. It's also a powerful tool in teaching. I mean, we are both in private practice, but the difference in the south of France is that we welcome residents and students. So you see I'm on the side there, being able to teach our residents how to perform the surgery. And as I told you, the learning curve is almost inexistent. So any residents that will change every 6 months, every year, its practice site will learn the machine extremely easy. This is a movie in action with Dr. Mercoli. This is to show you how we get from the machine on the side and a little bit about the volume of the machine. Dr. Mercoli has a very big operating room, which is not my case, but it adapted very easily to any type of operating room. Here we are draping the machine. It takes about 1 minute, 1 minute and a half. And this will allow your both arms to be sterile and approach the operative field. I will just show you, maybe I'll just get out of this presentation just for a second, so because the movie is a little bit long, but I will show you in real on an uncut basis. I will show you how the whole thing gets from the outside to performing the surgery. So once it's performed, the assistant just clicks. I think this is a bypass. So he just pushes on the button and then the machine knows which was the previous position of Dr. Mercolis for the bypass. And so it's adapting straight away. So every time you're using the machine, the amount of time to set up is getting lower and lower, and is getting more and more efficient. Even though each patient is a little bit different, because of the versatility and the light and how light is the machine, it's adapting. You see how we're putting the couplers. It takes about 2 seconds, 2 or 3 seconds per arm, and then you can plug in, you can dock the instruments that you want to have on your robot arm. It adapts to any instrument, and then you get a light feedback that the machine is connected. Just to show you a little bit going high-speed mode, this is a full gastric bypass. And you see, even if he's using even if it's docked, the instrument here is still extremely light to move without any problem. So it will act as a very powerful assistant. Now, just to show you how we get out of the surgery, you see that the arms are, at the end of the day, not moving so much, even for a procedure like the gastric bypass. And now, just at the end, to show you how we get out of the surgery, to tell you that if you have any kind of problem and you have to convert, it takes 5 seconds to take out the machine. You undock every instrument, you push back the arms, the assistant takes out the cart, and you're ready to go if you have to go for a laparotomy. So the conversion time, just to take out the machine, to undock the machine, is around 15 seconds. Switch back to presentation mode. Yeah, this was a cholecystectomy, but yes, that is a bit of an aesthetic movie, but it's actually interesting because it shows you how light it is. It is the maestro system, and we've plugged, I don't know how you would say, the baguette of a chef d'orchestre. In French we say chef d'orchestre, so the one orchestrating the music. And you see, this is how light it is. If you have to move your instrument, it's extremely light. But as soon as you want it to be stable, it will be extremely sturdy. So I would say it's probably light as a feather and strong as a rock when you need it to be. So this is definitely, with the AI-powered machine computing system, this is definitely what is enhancing the quality of your surgery. A little bit of data about what we did during the pilot. So the whole system setup with the docking was around 3.5 minutes in the north of France. We did 4 minutes, but we have a little bit more turnover with emergencies, a bigger staff, which it's changing. So that means people have to, learn every time the machine, but you see that we have only 30 seconds more. Going forward with the data, I was talking to you about the learning curve, and you can see that it's almost inexistent. This uncontinuous line is the average time that Dr. Mercolis takes for a bypass. And you see that straight from the beginning, his second case, third case, fourth case, he probably had, I think he had something about with the liver over there, but otherwise, you see we're just dangling around this average thing. So really the learning curve is almost inexistent. These are patients in and out from the operating room with the maestro system in the south of France. And actually the blue box, which is the maestro, gave us a little bit after some cases, it made us gain some time during our workflow in the surgery. So in conclusion, extremely rapid setup. It has also the force feedback. The strength feedback is included in the AI in the arms. So that means that you feel exactly the strength that you want, which is, for robotic surgery, a luxury that doesn't exist in many robots. To my knowledge, it doesn't really exist with the Da Vinci 5, as we had a great talk about it. You get some sense of a feedback, but here it's just a real live feedback. Even with the instruments, obviously with the instruments that are docked, you have a feedback that is almost like human touch. The learning curve, I don't think it's even short. I think it's just inexistent, and you have a broad application. It will adapt to any kind of laparoscopic surgery that you would find. Just a small word about how it's adapting to the OR. It's powered by a 3D camera in between the arms, and it's capable of heat mapping. So that means that it understands the whole OR, and it understands also the distance from the table. This way, if I show here, this way, you will see that you will see on the right screen that it's mapping in 3D. So that means that if you're tilting the table, if you are doing some Trendelenburgs, anti-Trendelenburg position, the robot knows how to not get in conflict with the instruments, with the surgeon, a little bit less because you can still be moving, but with the table and all the static things around. This is just a word about a very powerful tool with the machine is the ScoPilot. So that means you can perform a solo surgery because the computing system is connected to your screen, but it adapts to any column. We did with Karstadt, we did with Olympus, we did with Stryker. So it's connecting to your classical columns, and it will take all the data from the screen, and then it can power this software that will allow you to be followed by your camera. And again, it's adapting to any kind of camera. The system can understand which instruments you're using. So here it was understanding it was a Karstadt hook, and it's also understanding what is coming from the left hand and the right hand. It knows which instrument it has to follow. Those circles will allow the surgeon to be followed, but some surgeons don't want to be followed at a high speed. So those circles can be adapted to your practice. They can be wider, so you have less ScoPilot, or at least at a slower space. And it's something that is very adaptive, also adaptive not only to the surgeon but to the kind of surgery that you want to perform. So that was it. That was the insight about the robots, the Maestro system, which is actually, if you want to resume it, an extremely intelligent, connected, extremely stable, easy to learn assistant, super assistant. Thank you very much.
Thank you very much. That was really interesting. I just want to clarify that this robot has got 2 arms. Am I right?
Yeah, exactly.
And the telescope is not part of the robot. It adapts itself to whichever telescope we want to use.
Exactly.
So that would have good cost implications because it's going to reduce the cost a lot.
Exactly.
And it's going to make it more versatile. So I'm quite impressed. I look forward to trying it sometime when the company does decide to bring it to India. And that was really a very nice presentation. Thank you.
Thank you very much. Just a small word. It's the robot is answering a question and a demand that was some kind of frustrative for a lot of laparoscopic surgeons. You have to be cost aware, being financially aware of realities of your OR, of the hospital, of the social security, and we want it, but still the robotic assistant gives you something. And this robot is probably answering this demand that is in between heavier computing system and just simple laparoscopy.
Sure. I think this is what most of us as robotic surgeons, we foresee the future, that laparoscopy and robotics are going to merge and become one single entity. And this is a very good example. Thank you.
I have a question. Congratulations, Dr. Benjamin, for this great lecture and development, and for showing us that sometimes less is more.
Exactly.
The minimalist robotic model of assisting laparoscopic seems to me to be a good solution and proposal. But I tell you that in Chile, we have the company Levita Magnetics, which has developed a similar system, but based in moving the clamp with magnets. Of course, these systems are not competition with the other more complex platforms like the DaVinci 5 or another platform. But my question is, if you have thought about using together or as a complement to other platforms, I mean to do hybrid surgery or collaborative surgery with other system platforms.
Yeah. Yeah, I'm using I use the DaVinci. I tried. There was this Israeli company who developed also a robot that was able to follow the instruments. So another kind of co-pilot. So I'm using different kind of platforms, but this robot answers probably 90% of my practice. The actual, it doesn't have this supplementary articulation that you get from a more complex robot. So if you have to go deep in the pelvis for a rectal surgery or stuff like that, then obviously a more complex robot will give you that. But for 90% of the surgery, bariatrics, stuff like that, the thing is, you don't want your shoulders to be in pain. You want a stable vision, and you don't want injury in the liver. And also, you want to be able to manipulate your data, so you need a computing system. It's easy to understand. You want a computer to analyze your data. If it's getting the screen, if it's getting every image from the screen, that means you can print screen, send it to, it's powered on, and it's 5G. So 5G, so it means you can send things, you can send data to physicians to, it's powered by a software, so it can be updated. So the possibilities are enormous. And each platform probably has its space. The only thing is you need to use the most cost-efficient platform for different kind of surgeries.
Yeah, Jorge, that was a great question, Benjamin. That was a great presentation. I think that we need to clarify that this is not a surgical robot. It's an assistant robot, and I think it's important because when you compare Intuitive or whatever other robot, those robots, you are moving the instrument, right? And the robot is moving the instrument. I think that the role, as you explained very well here, is in a world where we need more and more personnel, we lack nurses and assistants. This system or Levita are going to be a great system because the surgeon doesn't need an assistant to do most of the operation, like you just mentioned.
Mm-hmm.
It was impressive that you can do the gastric bypass and esophagectomy. Really proves, that. But you are a good surgeon. Some surgeons need the assistant to support them, right? So you have nobody to blame. When I made a mistake, I always blame the resident, right? So Benjamin, the last part, the tracking of the instrument, is that readily available right now, or that is still on the is that available in today?
It is available. It is completely available. I had to skip because the talk was going to be too long, but I have a whole movie with a cholecystectomy that was performed only with the scope pilots thing. Yeah, because
that is a game changer. The fact that you don't need an assistant giving you nausea and vomiting because he's moving the camera up and down really going to be very useful.
But that's what I'm maybe because you always have ideas when you see things, when you see the principle of it, and then after 100 cases, things you have different mindset. And I have to say, in the beginning, you might think, okay, I will maybe need one less assistant, but I have all the assistants I want. I have 3 or 4 residents. I have a dedicated assistant, a scrub nurse dedicated for that. If I have to do the operation, and I have all the assistants I want in the world, I'm gonna take the Maestro because the stability it's more than just holding instruments.
No, I have used it here at UCSD in the lab, and it's impressive how light it is. And it shows I have never seen anything like it. It gravitates in the air. It's really impressive, really impressive. And the fact that can learn where to put the arms. Marco, I see you wanted to ask a question. You always ask smart questions, so
yes,
let's
excellent
challenge
presentation.
Benjamin.
Nice presentation, excellent data, excellent demonstration.
Grazie.
The point I would like to point out is, as you showed at the beginning of your presentation, it seems like this one, even if it is an assistant robot, it could help to give your assistant more detailed teaching. So leave you free to teach him how to operate, not how to assist. So I guess that is not to avoid having any assistant, but probably it will be a good way to teach in the future, because you have assistant maneuver done by the robot, and you can help much better your assistant while teaching. I guess this is the main impression I had. Thank you for sharing.
Okay, Juan, any last minute question? And if not, I'm going to close the meeting.
Yes, Professor Carrier,
Yes.
outstanding presentation. Today we see platforms with open and closed cabins, robotic system with a tower with several arms, or with several towers with a single arm around the patient. When we talk about robotic surgery, the first thing that comes to mind is a console and a patient card. Do you think that the Moon surgical master system is really ready to concern intuitive and Medtronic?
Well, it is. So first of all, it's CE marked. It's going to be FDA approved within the next month, probably. That's what the company told me. It is not a competition towards the robots of Medtronics or the robots from Intuitive. It is not giving you the same objectives. This is full laparoscopy enhanced with AI. So it is also it's already completely ready to be implemented in anyone's practice, in anyone's laparoscopic practice. It is the limit in between robotic surgery and just classic laparoscopy. As you have those co-pilots, it's powered by AI, but it is not ready to competition Medtronic's robot or Intuitive's robot, because it's just simply not a robot in this matter.
Yes, that was very well said, Benjamin. We need to separate them, because this is fitting an area where Da Vinci, Hugo, Mantra don't fit. Those are robots to operate. This is for the 90% of surgeries we do that we don't need a robot. And I like what Marco said about the assistant teaching, because sometimes we have to tell the nurse, can you grab the instruments so I can grab the resident hands and move them? And here, the instruments adapt by themselves and you don't need to do anything. So I think that for teaching, and I really like it a lot. Well, thank you, everybody. I think that I was told that we need to close this session. We can continue talking for hours. Very impressive, the three presentations, great questions. Jorge, you want to say something else, and then we pass it to Dr. Ortiz?
This has been an IBC Oxford University Hot Topics and Surgery production. I want to thank my co-chair, our moderators, and our distinguished panel of experts for their valuable time and talent today. We want to acknowledge all our partners and sponsors, as our global collaboration proves safer and better outcomes. To view the complete Hot Topics and Surgery series, subscribe to our IBC YouTube channel and follow us on our social media platforms. And don't forget to mark your calendars for the 5th IBC University of Oxford World Congress, which is taking place 17th through the 19th this September of 2024. At the University of Oxford, United Kingdom. For more information, go to ibcclub.org. And now let's view another brief episode of IBC's exclusive Spotlight on Industry and today's sponsor. From IBC Global, stay safe and God bless.
Intuitive Da Vinci 5 is our most advanced and integrated system ever. It's going to transform surgery for surgeons, care teams, and patients.
Well, I've never seen anything like this before. Force feedback is a first-of-its-kind technology. In preclinical trials, we're seeing up to 43% less force on tissue. That translates to gentler surgery for patients.
Before, we relied on visual cues primarily, but now with feedback, it does give you that extra sort of sense.
It's not something I've seen with any other system. It's something we experience in open and laparoscopic surgery, but not robotic surgery.
We're going to be able to control so many more things from the surgeon console now, which I think is really important.
It's really an immersive experience that gives you a next level of control that you didn't have previously.
The ergonomics, the ability for me to move the headset where my head goes in and move it exactly where I want it to be in a variety of different positions. I think that really is going to help elongate my career and make surgery more comfortable.
We are seeing Da Vinci 5's capabilities result in faster surgery, which translates to our customers' ability to do more surgeries in a day.
I think having the integrated new components will make the process of starting the case a lot more efficient.
The insufflator being in the vision tower is just a huge thing.
We don't have multiple vendors within a tower. We literally can offer everything that we need for the patient under one umbrella.
I think it will make rooms more organized, so it helps with the staffing problem that we have, and also helps to reduce the cost.
Da Vinci 5 will help surgeons unlock new answers to surgical techniques and patient outcomes with unique and granular data. Da Vinci 5 connects more data than any other platform that I'm aware of and allows physicians and their administrators to link them to patient outcomes.
This opens up an opportunity for years of innovation and years of things that are going to come next.
I can't wait for surgeons to get their hands on this.
Now we have a platform, an approach to do minimally invasive surgery that is beyond anything that we could have seen in those incremental improvements. And that is what's giving us the magnification, the stability, dexterity, ergonomics, precision, all of which are key for us to be able to provide the highest quality minimally invasive surgery that we can to our patients.
We don't want to be behind in medicine. We need to be ahead, and that's what's really exciting about this next generation.